Okay. Hi, everyone, and thank you for joining us for our webinar today on pain management skills for the entire primary care team. We'll be exploring principles and tools that just about any member of the care team can use to really help patients in managing chronic pain, but especially right now in our current climate where we're in the midst, as we all know, of an opioid crisis, and just about everyone from patients to clinicians, but also families and communities, I think everyone's experiencing on some level this pressure and this pull and push between both relieving or at least managing suffering, but also preventing avoidable deaths and keeping people functional. So I'm Andrew Phillip. I'm the Senior Director for Clinical and Population Health with the Primary Care Development Corporation. And I'm joined by our co-sponsor for this webinar, Dr. Neftali Serrano, the Executive Director of the Collaborative Health Care Association. Neftali, do you want to let people know a little bit about CFHA and you do the same here?
Sure. Yeah. So we're very pleased to be joining Andrew and the Primary Care Development Corporation on hosting this topic. It's a topic that's really close to the heart of our membership. We're a nonprofit member association dedicated to promoting the integration of physical and behavioral health care across the U.S. healthcare system. And our members are folks who are on the ground in primary care clinics and specialty care clinics, really dealing with the opioid issue and the related and overlapping pain issue in the United States. And as Andrew said, really our main interest in co-sponsoring this webinar comes from, frankly, the pain that a lot of our clinicians feel at dealing with this issue, both because we're compassionate individuals who care about our patients and want to help our patients as much as possible, but also because we often find ourselves in quandaries around ethical quandaries about how to best provide the best possible care, especially when patients are asking for things like pain medication that we don't necessarily believe, based on the research, is going to be the best possible care. And this and many of these kind of quandaries are what led us to kind of say, hey, let's see if we can host a conversation with folks who really can give some practical tools and counsel on how to approach this situation. So I'm not going to belabor who we are because I know you're here for the webinar content, but you should just know that CFHA is a great professional home for folks who are interested in integrated care. And one of the main things that we do each year that's a highlight of the year for CFHA members is an annual conference. If you're interested in topics like pain management in primary care and other settings, in integrated settings, you can certainly join us in Philadelphia. Our next conference is in October 8th through the 10th. And you can find out information at integratedcareconference.com. So we hopefully try to make it easy for people to find us. But I'm really excited to hear today's presentation and be part of this conversation, Andrew. I think this is a really great opportunity to further a conversation that got started a few years ago as clinics had to kind of start putting in protocols to change their pain management practices. And people are just now, I think, settling into routines and protocols that are new standards at their clinics, but they're still feeling the pain related to how to really manage these difficult patient populations.
Yeah, absolutely. Again, I think this is timely, and so let's just jump right into it. Just cut through a couple of slides here. So our presenters today, I'm very excited to announce them. So first, Dr. Jennifer L. Murphy. She serves as the lead manual author. She's a master trainer and subject matter expert for the Department of Veterans Affairs Cognitive Behavioral Therapy for Chronic Pain Treatment Initiative, and she's also an associate professor at the USF School of Medicine. Dr. Murphy is a co-investigator on numerous funded research trials focusing on the applications and outcomes of cognitive behavioral therapies for chronic pain, including its use as a treatment aid for those tapering from opioid analgesics. She's on the editorial board for Pain Medicine and frequently speaks on the role of non-pharmacological treatments for chronic pain. She's also developed with us a tool for discussing pain with patients, and we'll share that with folks who join the webinar today as well. We're also very fortunate to be joined by Dr. Michael Hooten. He is a professor of anesthesiologist at the Mayo Clinic. He is the author or co-author of more than 80 peer-reviewed scientific publications, and in addition to his role at the Mayo Clinic, he's a section co-editor for the Journal of Pain Medicine and associate editor for the Regional Anesthesia and Pain Medicine, and he has served in various leadership capacities for the American Academy of Pain Medicine, the American Society of Anesthesiologists, and the American Society of Regional Anesthesia and Pain Medicine. Most recently, he accepted a director-at-large position on the board of directors for the American Academy of Pain Medicine. So we're very honored to have both Drs. Murphy and Hooten joining us today. And with that, I will turn it over to them.
Hi, so I'm leading things off today. First, I just want to say thanks so much for our hosts for the interest in this subject. That's very near and dear to us, as well as to the people attending, your interest in hearing more, learning more about things. And hopefully today we'll be able to have a good conversation, answer some questions, maybe discuss some difficult topics, and really focus on how we might be able to apply some behavioral and medical strategies a bit more effectively in our management of individuals with pain who may or may not be using opioids. So, just to start off, I don't want to belabor the point too much. I think, we all know that there are sort of these dual issues that are very prominent in our healthcare system right now as crises that we're sort of trying to address concurrently. One is a very long-standing one of chronic pain, and really thinking about what's the best way to effectively manage pain as a whole person issue. This is something that impacts us on, a human resource angle, financially, and at the same time, over the last 10 to 20 years, really, we've seen changes in prescribing that really sort of initiated a crisis around opioids, which has shifted in recent years to something a little bit different. But we do want to, of course, acknowledge the overlay between pain, which is really, what we're interested in is how do we help people live their best lives despite their experience of pain. Sorry, trying to see if I can advance this. Okay, got it. No, sorry. Okay. Okay. So this, sorry, should have advanced this a little bit sooner. But this is really, just, I thought, a nice quote about, the acknowledgement, basically, that we're sort of trying to deal with both of these things at the same time. And at the end of the day, we really want to help reduce pain-related suffering in the many patients that we see and that we care for, and try to arm providers with more tools to be compassionate with them and also help them live their best lives. So that's what we're going to be focusing on today. The context that we'll be talking about these issues in is really a biopsychosocial approach or model. A lot of times, the way that pain traditionally has been addressed, and also really is just most typically understood in our pop culture, so to speak, is as mostly a biomedical experience. And oftentimes there's not as much attention given to some of the other factors that actually impact pain so significantly. So, our foundation in this discussion is to say, one, there are biomedical and physiological issues that need to be evaluated appropriately, figured out. Dr. Hooten's going to speak about those kinds of issues, what questions should be asked. And at the same time, while we're looking at those things, also knowing that there are these behavioral, environmental factors, psychosocial factors that play a very big part in an individual's experience of pain, and also in how pain treatment outcomes occur. So we know that these psychosocial factors weigh significantly on the effects of any intervention, be it a surgery or a behavioral intervention. They all very much are impacted by a variety of factors. And so that's something that we know isn't always acknowledged and is very important to make sure that we have in mind. So again, this is, we know that this is sort of the gold standard, but what we see a lot is that often behavioral interventions aren't necessarily considered or thought about too much, or we don't think about this very complicated person in front of us and what are the different things that could be turning up and turning down the volume on their pain, and how might we impact those. So instead of waiting, until somebody is very far into a chronic pain experience and say has already had a number of interventions that have not necessarily been successful, we just want to talk about how do we, from the as early as possible in the primary care setting, really conceptualize pain as this whole person experience and introduce the whole, gamut of options that we have for treatment that we know are evidence-based and effective right from the beginning, instead of waiting until things have maybe gone another route. Related to that is really this sort of parallel process that we see a lot of times for individuals who have chronic pain, and particularly those people who have maybe struggled in their relationship with opioids. There's often this, process that occurs both on the patient side as well as the provider side. And sometimes that can lead to this divide and, frankly, a very unfair reputation for individuals with chronic pain as being, problematic. And I'm sure Dr. Hooten and I have both experienced many times questions about, why would you choose to work with this population? And so it's a very unfair reputation, I think. And a lot of it is born out of individuals who have pain, their frustrating experience with chronic pain, a lack of maybe having diagnoses that are satisfactory, not necessarily getting treatment that's particularly helpful, perhaps feeling disbelieved by people in the healthcare system. And so really just feeling frustrated and at their end of their ropes. And sort of at the same time, you have providers who are experiencing very similar things. They want answers that are sort of the objective kinds of answers that we like to have in medicine. They want to see progress with their patients through maybe the things that they immediately have available in their toolboxes, such as pills or procedures, and maybe they're not getting the outcomes that they would like to see either. And also, just really having these questions about what's really going on here, is something else happening, and everybody kind of having this shared helpless type of experience together. And a big part of that is because this is often a person who has a high level of complexity. Everybody, of course, isn't like that. And some of the more straightforward cases maybe can be handled a bit more easily, at the primary care level, people who are very motivated, especially for engaging in a lot of self-management. But a lot of what we see, doesn't necessarily fit into that. And the cases that are most challenging for us typically don't fit that. And we have different types of resistance and struggles around effectiveness and how to approach things. So, Dr. Hooten, I don't know if you want to talk a little bit about, just the fact that these things are sort of tied together nicely in these recent guidelines that came out.
Yes, so I do think the recent guidelines are helpful because they do emphasize the importance of this parallel process, as you described, moving forward in both a biomedical but also a psychosocial approach, so that individuals can receive treatment simultaneously using different modalities. And as also you suggest, the vast majority of pain outcomes are driven by psychosocial factors. And the earlier those factors are recognized and intervened upon, hopefully that will enhance both short and long-term outcomes.
Yeah, and thank you for saying that too, because I do think that's a really important point, which when you, like I am, when you're more sort of embedded in this chronic pain world, and especially with a primary care audience, I think it is really important to talk about, you know, the transition from acute to chronic pain, and the fact that many of the things that we're going to talk about are ways that really we can think about it in terms of prevention and wellness, which is often very much a focus in primary care, and a way that we can not only help those people that are further down the path, but hope to actually convey some things earlier on to avoid some of those less than favorable outcomes that we might see later on. So this slide's really just talking about the anticipation for this webinar was that a lot of the audience would be prescribers. And I just think it's really important as someone on the behavioral side of things to really emphasize what a powerful sort of voice you have as a prescriber, and why I feel like it's so important to communicate these messages across the healthcare system, but certainly to those in the medical field who are the prescribers, because oftentimes you hold the most significant weight with the individuals who come to see you about pain. And so the tone that you set and the way that you address things and sort of what your beliefs and expectations are really impact how that person kind of proceeds in their care and what they believe, you know, may work or not work for them. So kind of changing this message from, you know, instead of measuring things on a 0 to 10 scale and having that be it, really shifting the conversation somewhat to a functional one, and what kind of outcomes, you know, they want to see and what's most important to them. So we're not going to get into at all sort of the details of the behavioral pain medicine kind of approaches that we use. We'll talk about it some as a you know, integrated into our conversation around these cases, since we want to spend the majority of time there. But just as a way of providing some background, I think a lot of times, especially if you're referring to somebody who's a pain psychologist or a psychologist who has health background, an individual who has pain, you may refer them, but you don't necessarily know what they do, or the kinds of things that they do that may be helpful. And what we're really talking about here, I think, is not, I mean, we want to sort of emphasize an understanding of what someone like that might do and how it might be helpful. But I think we also want to talk about how a lot of these things, if not all of these things, you know, we should all be really speaking the same language. So all of these things are things that people in a variety of disciplines can introduce and talk about and touch on. So, you know, just providing the basics around pain education, the differences between acute and chronic pain, the natural progression that many people face into a sort of a fear avoidance pattern around movement, how we can pace activities in a way that minimizes pain flare-ups, the role of expectations in pain outcomes. So sort of retraining our brain to some extent for how we respond and react to certain things so that we experience pain differently and it has less negative effects on our life. Relaxation, or I prefer really to use the term physiological self-regulation, because individuals with pain tend to respond to that better. But how can we change our own physiology? What are some things that we have at our fingertips to be able to really, you know, change what's happening in your body in response to your pain so that it doesn't impact you in the same negative ways? And at the same time, how can we really, you know, bring up the level of positive activities in your life and move away from some of those things that have become harmful or isolating or detrimental to your functioning. So all of this is often tied together in let's, you know, put together a solid pain action plan. So what are the things that I'm going to do as your physician? What are the things that, you know, I may refer you to? What are my strategies? And what are the other strategies that we need in order to make this a successful treatment? And these are some of the things that also need to be incorporated at the same time. You know, we also know that these are a lot of things that can be, just to loop it back into the opioid issue, a lot of the things that can also really be tools to help make a conversation around reduction of opioids or possible reduction of opioids more successful. So, you know, oftentimes people have this experience of feeling like maybe they're being abandoned in some way, or you know, there isn't as much communication there, or, well, if you're going to remove this, what am I supposed to do when X, Y, or Z happens? And so some of these things, you know, are things that can be used very directly in terms of, you know, a very small, say, reduction in opioids, and also incorporating relaxation techniques when you feel an increase in stress or anxiety or pain, can really prevent someone from taking that other dose of opioids that maybe they're considering taking. So really using some of these concrete strategies as a way to make that process more successful as well. You know, we know that in primary care, and so we're going to focus on this, you know, the considerations are different maybe than in a more of a specialty clinic. So Andrew mentioned the guide that I helped put together for their organization, but part of that's really in the structure that we're going to use is, you know, we want to keep the message simple. Time is of the essence, and we want to make sure that we're able to say things in a very sort of consolidated way that resonates with our patients. And also, as we mentioned, just not delaying bringing these things up. Language is just something that's sort of a peeve of mine, because I think it's one of these things where we can either sort of sink our ship or get someone on board with us and make things a success. So the way that we talk about some of these behavioral strategies especially is really important. We really want to stay away from, this isn't about a mental health issue. This isn't about somebody being, you know, depressed, or this isn't about you know, someone not being believed. So but these are really about, this is really about, you know, treating you as a whole person, because pain is complicated and there's all of these different factors that we need to attend to, or we can't expect things to, you know, necessarily have an excellent prognosis. So Dr. Hooten, do you want to start out our first case here?
You bet. So we'll talk a little bit about Juan. Mid-50s-year-old gentleman, married, new patient in the clinic, low back pain. That is a very, very common set of basic demographics that you'll probably encounter on a daily, if not weekly basis. I work exclusively in a pain specialty clinic, so this is the typical type of individual that I might see literally on a daily basis. Low back pain for 12 years, worsened after a spinal fusion. And of course, we know that that is also very, very common because of adjacent segment disease and other factors. And just development of new spinal problems can drive new pain symptoms. Finally, a poor medication regimen includes high-dose opioids since the last surgery 3 years ago. We also have a big, big red flag that psychosocial problems are present, primarily by no work for the past 6 months. And again, when we see lack of work, we know that there's other problems probably brewing as well. There could be family issues. There could be problems with literally pain intensity, getting mobilized. There could be loss of social activities, loss of self-esteem, and other problems, including, you know, the possibility of depression and some anxiety-related pain problems. So his story, as he says, as he tells you, my last doctor told me that I needed to go down on my oxy, but that's the only thing that takes the edge off. We hear that very commonly. I get upset with them not listening to me, so I left and decided to come here. So he feels unheard because maybe there's some tensions and questions around opioid use. This office is closer to my house anyway. I just want to get this pain fixed. I can't believe things got worse after my surgery. I want to I want to get back to work, but there's no way right now. I'm always a 9. And as we can just, hear him present his problems, Jen, we can see that there are a host of possible cognitive problems there, and that they're clearly resulting in some maladaptive behaviors. You just want to kind of focus possibly on some of those?
Sure. So, yeah, I mean, this is kind of just a really typical reflection of just an average person. So not, on any particular end of the continuum, but some of the things that really jump out. One is this sort of expectation of, despite this failed surgery and things actually worsening, I just want to get this pain fixed. So there's still this focus on, instead of a focus on management, there's a focus on elimination. And instead of a focus on, maybe things that are a bit more functional, there's a focus on, I need my pain to just go away completely. And we know for most people that is not a realistic sort of expectation to have, although it is something that many people hold. If they haven't either been educated in the right way or really been open or understood kind of the pain process and what reasonable expectations are. And then I think the other thing that jumps out is just the I'm always a 9. I mean, that kind of also suggests this biomedical kind of focus on a number versus what does that number mean? What does that look like for you? Let's start talking about how this translates into your life. How can we operationalize that? And of course, we would also want to follow up with, the oxy being the only thing that takes the edge off. One, just what does that mean exactly? But also, what other things has the person tried as far as treatment goes? And if they did not work as far as his perception went, why didn't they? What happened in that scenario?
And can I also just build on that, Jen?
Of course, yes.
One more time. Can we just back that slide up possibly?
Absolutely.
Because I would also, as you suggested, this last little statement, I'm always a 9. And when I hear those types of statements, I'm always extremely concerned about pain contingent lifestyle. So this individual will more than likely wake up in the morning, assess his pain, and there's some level in his own mind that if my pain's a 9 or this or a 7 or whatever, I can't do A, B, or C. And this individual's already progressed to the point that there's a certain pain cutoff that will not allow him to get back to work. And so as we think about his expectations for treatment, but also improvement in functionality, in my mind would be a key factor that I would be working on and talking with him about from the get-go.
Absolutely. Yeah, no, that's a great point. So, I mean, this is just kind of a framework for, based on this guide, we came up with, where it's really sort of 6 steps to approaching individuals with pain. And so, again, this is our framework, but this is certainly, not something, this is more of a way of just things that we want to really have in our interactions, in these kind of interactions. One of them I think that's really important, and one of the struggles often in these challenging conversations can be first and foremost to just legitimize pain, legitimize the person's experience, acknowledge that their situation is frustrating, that this is a loss for them, that you recognize that they don't feel like their old selves, that they understand that this doesn't feel fair, that you believe everything that they're saying. It's just one of the biggest frustrations that we see in the population is just not feeling heard or understood. And I think oftentimes if we just make our kind of first part of our interactions and conversations around legitimizing, acknowledging, and sort of reflecting back and also saying, I believe you, I hear you, and that sounds like it's been really difficult. Sort of people especially who could be more resistant on the front end or defensive sometimes, you know, it's the point is not to disarm them, but we want them to know that we do believe them. This is a you know, a safe place to be. Let's continue this conversation. Let's stay open. I think the main thing is, no matter what good things you have to say or share with someone, if they're not open to listening to it, or if they've been, you know, shut down because of something that's happened in the past or something that's happening in the current conversation, then you're not going to be able to make much progress. So it's a really, really important kind of first step. Mike, do you want to talk about the function piece? I know we share that belief strongly.
Yes, yes, but I would also just like to back up a little bit to the legitimized pain statement, because this is so critical. And in my work daily in the pain clinic, I found that it's so important, and individuals not only feel heard, but they feel like I'm taking their symptoms, you know, and that they are legitimate symptoms by performing a very detailed history, past medical history, HPI, just go back to the basics. I do a very thorough physical exam. I'm looking at imaging studies, and I can demonstrate to that person what my physical findings are, what my thoughts are about their imaging studies. And even if they've heard the same interpretation 5 times, at least they understand that I've taken the time to do the basic work and lay the framework for ongoing treatment, because understanding their anatomy, understanding the physiology of what you're dealing with, even the pharmacology, unless that is concrete and you're just 100% sure about it, it's very, very difficult to push on to start thinking about other approaches to managing and enhancing pain outcomes, specifically focusing on function. And one of the key aspects in my own experience is that shifting or transitioning from an acute biomedical more to a chronic pain management model is so important, and demonstrating to people that you can be functional despite having that pain level of 9 or 8 or 7, and helping them recognize that a certain pain score is not necessarily a limitation to moving their functionality forward.
Yeah, I think that's so important, and I think a lot of the feedback that I certainly hear from providers is really about, you know, how do we try to move away from just using that number, or if we're trying to set goals, you know, for treatment. A lot of people try to incorporate, of course, you know, goal setting as a way to, you know, move things forward or shift towards function. And often the goal is, you know, a pain of 0. So just to kind of, you know, a really simple strategy is, you know, okay, so if your pain was less, what would that look like for you? What would that mean to you? What's one thing that would change in your daily life? So just kind of trying to really make concrete, you know, what the meaning behind something that's being said is a way that, you know, just to sort of get at that function piece a little bit too, in the conversation that can be really challenging sometimes. This next piece, you know, we've touched on a little bit, but I think it is this idea about how important it is to kind of understand expectations coming in, and then also try to work with those, provide education in a very compassionate way. But what, you know, may or may not be sort of reasonable in terms of next steps, how we can really, again, use function to, instead of, you know, focusing on the fix part, really focusing on how can we best make your life bigger so that your pain feels, you know, smaller and less overwhelming by comparison, and that's really what we're trying to do. The sort of goal is improving your function and making your life better. And there's a lot of different ways that we can do that. And the only answer to that isn't, you know, the pain of zero. I don't know. Do you have any comments on that?
Yes, and in fact, if even the first time that I'm seeing someone, if there's a clear statement or a strong suggestion that the individual is here to, quote, get fixed, end quote, I will address that straight on in a very empathic manner. So after I've done my basic work, I've done my physical exam, I've looked at the imaging studies, or in this particular case, even looked at his operative notes, and I'll be very clear that with them that, you know, there's no way that I can fix pain, right? That I can eliminate your pain. However, I'd be very interested in helping you cope better, manage better, and hopefully live a more productive life, shifting from a palliative type approach versus a very rehabilitative approach with defined goals. And some people will hear that and they're okay. Other people, I might not see them again. But again, that's the approach that I will take so that we can kind of try to align our expectations from the get-go.
And I think another important thing you just said too, and this is especially true for, I mean, it's true everywhere. I just, you know, I feel like primary care probably, you know, feels that a lot is you may have to say the same thing or deliver a similar message, which is, you know, the truth, what you just said. Somebody may not be ready to hear that the first time or the second time or the fourth time, but you really, you know, have to continue to put that information out there, and to be compassionate and to share that as, you know, this is how we're going to move in this direction of rehabilitation, of helping you get your life back. And it may take time. And so that's why I always think in primary care, you know, the earlier you can say it, and also, you know, realizing you may need to say it every time you see the person for a while, and that could be months and that could be years, and you just don't know, before things kind of click or before they're really ready maybe to engage more fully with a lot of the things that you're talking about in terms of the plan. And so that's really related very much to this engagement piece, and sticking with them, and sort of waiting until they're ready to engage, continuing to offer things, and really trying to introduce some of these tools that we have that can help with better managing the way that pain impacts your day-to-day life. So again, you know, we know there are tools that you can use yourself anytime that will actually calm your nervous system, which is sort of keyed up and not working for you and not helping you right now. There are strategies that we actually know work, and they're very accessible, and they're pretty easy if you're willing to try them. And so instead of amplifying those pain signals and that pain experience that you're having, these are things that can help dampen it for you. So really just, you know, trying to use simple language around some of the key strategies that we know can be helpful. All right. So I sort of hit on the strategies part, and just in the interest of time, I want to keep moving because we also have another case to get to. Mike, I don't know if there's anything else that would be helpful for you in terms of, you know, maybe the support or how you would work with this person, especially if it's somebody who maybe is resistant to medication changes.
Yes, I can probably predict up front this individual is going to be very reluctant to make any changes in the opioid dose. For example, let's kind of hit right to the heart of the matter. Now, if he's using the medications in an unsafe way, an extremely high dose, or if there's other behaviors or problems that put the individual at high risk of an accidental overdose, then, you know, I would be compelled to intervene, right? But if he's been using, you know, an acceptable dose, and I would suggest, you know, under 90 morphine equivalents, for example, and there's no other risk problems there. For instance, you know, use of other, high-dose benzodiazepines or other substances, then I would work with him over time to try to facilitate and drive the opioid dose down, for example. But again, that's only going to occur in the context of developing a longer-term strategy, as you suggested with this next bullet item, to help him understand that there's other treatments available. And if he could adopt and incorporate some of those other functional treatments into his daily life, then he may be more willing to consider reducing the opioid dose.
Okay, thank you. This just kind of ties into what you said a little bit, but I think, that what you were saying about okay, but what about my opioids, still being kind of, that's still front and center, which is not unusual. Like you said, it may be somebody where, we can, let's just, especially since this would be, a new patient, unless there's some sort of acute danger or something else that you feel compelled to work on immediately in that area. I think it's good to really be thoughtful about those changes, take time, establish a relationship with somebody, and not think about other behavioral strategies as an either or. So I'm always just talking about, okay, and also if we're using these things, then we're going to be able to better manage your pain. You may even find that you have less of a need for your opioids, but let's just see what happens if you're willing to explore those areas. So, I think one of the things we get into sometimes is trying to, convince people of this over this or this instead of that. And the way that I feel like you can be more successful with patients is to sort of, one, if you are tapering, obviously just come up with a collaborative, slow, reasonable plan, but then also not make it about an either or situation, but just we need all of these things working together if we want you to get to the best place. And so it doesn't have to be like that. And this is, the ACPA has this great video, but this metaphor of, medication maybe is going to fill up one of our tires, but if the other three are still flat, we're not going anywhere. So we have to address all of our tires in order to get the car on the road, to get going, to be successful. And we can't just focus on one thing when we have all of these other things that are so important in the process as well. Okay, so let's move on to our next case. This is a 32-year-old female, somebody you've been seeing for a long time, maybe 5 years, maybe 10 years. She's only taking NSAIDs. She has some neck, shoulder pain. She also has some pain that's a little bit tingling, shooting down her arm that she's concerned about. She's also had these headaches for the last couple of years. Now they're getting to the point of being almost daily. And the pain's just really worsening over time. She's feeling pretty hopeless, helpless, doesn't know what to do, and is employed. Is a dog groomer, has, a fairly active life in that way, although she's doing less and less socially, but she's really concerned about the future, especially given her age. So her kind of, presentation to you when she comes in is, I can't believe this pain keeps getting worse. By the end of each day, my neck and shoulder are a mess, and I'm getting headaches every day almost. I don't want to take any medications because I need to be able to think, and I just don't have the time to go to PT again. I'm so stressed about everything. So this is sort of, her presentation when she comes in. So Dr. Hooten, what are your kind of all around, medical and otherwise, what are your thoughts for this young lady when she comes in?
Yes, so my internet connection kind of went down just a little bit, Jim, but now I just caught the very last statement that you made. So bottom line is, what are my concerns about this young individual?
Mm-hmm.
I would be very concerned in these types of situations, as we all know, especially in the primary specialty setting. These individuals are difficult to assess because there's a variety of symptoms covering multiple body regions. And then of course we have headache on top of it. So I think it's critically important to do a very thorough diagnostic evaluation, good physical exam, good history, and to identify some underlying pathophysiology to explain what is going on. So for example, it's a very young woman. The odds of her having some type of cervical radiculopathy or radiculitis probably low, unless there's other signs or symptoms that may suggest she has a subacute or an acute disc, for example. Does she have primary shoulder pathology? Well, more than likely not. However, if she's a dog groomer and she got some 80-pound dog and she was wrestling around, it's possible she could have some derangement of her shoulder. But then also, as a dog groomer, she's going to be probably contorting herself and her body on kind of a repetitive manner to groom the dog. So she just may have a myofascial component. But again, I think it's so important to identify the primary underlying pain diagnosis, which is probably one, but she may have two, because it really helps formulate very clearly expectations for treatment. So those would be my primary concerns as I saw her medically, Jen.
Okay. So that's really helpful, and I think also incredibly useful and validating for people who may frankly have not been evaluated sufficiently in the past, to have somebody who actually takes the time to look into things and really try to figure out, can we figure out exactly what's going on here? From my perspective, sort of in the meantime, we're working with a great physician who's doing all of those things. And also, I think a question that I would ask, and also a physician could put, I would suggest can do this as well. And this is a way to sort of integrate things, I think, is, so we're going to move forward with a plan to do the evaluation and figure that out. In the meantime, based on what we know about this person and their presentation, we know that, just to take the most basic and accessible piece of this, that they're having headaches every day. And it sounds like most likely these are tension headaches. The most common kinds of headaches that we see are tension type headaches. She's telling us very, very clearly she has a lot of stress in her life. She's very concerned about her situation. And also she's getting these headaches now on an almost daily basis. So one of the things we could do very easily is, talk about what are our next steps in terms of workup. And also for today, what can we talk about, in terms of the headaches? Because that's something that we could potentially start to work on immediately through a behavioral approach. And so something like using, again, just a self-physiological intervention like relaxation techniques, which we know are helpful in reducing muscle tension. We know something like biofeedback is actually helpful in teaching people how to navigate their own physiology and make the changes that actually can reduce headaches significantly, can reduce physical and emotional stresses. And also, as a secondary, maybe next visit or the one after that, depending on what happens on the medical side, we also would maybe want to talk to her about pacing. We don't know exactly how she's approaching her activity during her work hours, and that could be very physically intense, and she may be doing that in a way that frankly isn't really serving her and maybe working against her physically and mentally. So these are just some talking points, but I think right now it makes the most sense, since we worked through those a little bit, and we're low on time here. I think to turn it over maybe to Dr. Phillips, I'm not sure, for questions or discussion around these cases.
Yeah, and Thanks, and I'll kind of have some of your take-home points here up on the screen. So we've gotten a few questions from people, and just so folks know, you can continue in our last few minutes here of typing your questions into the chat box. But the first question, I think this is a pretty good one. So, we're talking about primary care teams in general, but a question about how does a care coordinator or paraprofessional also support this process and that collaboration and I suspect communication between the provider and the patient, given like what you said, that so many times, our patients are coming to us and they're already at wit's end. They're already feeling like they've done so many things. How can they help in that space?
Do you want to answer, Mike?
Well, so let me just clarify that just a little bit, Andrew. How can...
So how can other members of the care team, other than the physician perhaps, or an RN, help out? So a care coordinator, for example, or even thinking about maybe others who are involved, peers, others who are not clinical staff. How can they support this process and maybe even this messaging that you're talking about around functioning and some other elements about chronic pain?
Yes, so unfortunately, in my practice, I don't necessarily have access to that resource. However, I do know, and I've talked with other individuals who have been able, for example, to incorporate a coach or a pain coach. And this might be an individual, the background, training is variable, but the individual basically functions as an advocate for the patient, an advocate for change, but also for trying to help that individual incorporate some of these more difficult or even abstract behavioral plans into their daily life. And that person is very helpful because they may be available on a more casual basis. So they may meet intermittently during the week, from what I've talked with individuals, or there may be electronic communications, texting, or other approaches to drive these rehabilitative treatments forward. I hope that adequately addresses the question.
And Andrew, I'll just add a little bit too. I mean, I would say really, to me, I'm everything that we've talked about, I really feel can be incorporated by a care coordinator. I think, validating the experience, being, critical, sort of, developing that rapport, and then reinforcing this biopsychosocial message that, I understand that you want this to be fixed, or I understand that this has been really frustrating. Remember, this is a whole person experience. There's a lot of different things that we need to work on to get you where you want to be. And sort of as Mike suggested too, I think one thing they can do, and this may be a little bit beyond, I think those are probably the most critical pieces, but if it is somebody that can also sort of reinforce goals, and really talk more about, and when I say goals, I'm talking like, well, what's one thing we could do this week to get you a little bit closer to X? So not run a marathon goal, but choose a store to go buy tennis shoes to start walking goal. You know what I mean? But that kind of follow-up is so incredibly helpful and important, I think. And so it's just such an important job.
Yeah, thanks, and thanks to both. I love this question. I think it's critical. I think it's really anyone who's interacting or touching the patient at all, it sounds like, has a role to play in this. I'm going to keep.
If I could interject real quick, because I think it goes to the question. I think it also speaks to what Dr. Hooten said before about upfront doing good education with the patient about what the nature, the etiology of the pain issue is, and the limits of what intervention can do, and then communicating that to all the team members so that everyone is on the same page. So for example, in my clinic, a clinic I worked at before, one of the things that I encourage providers to do is, in the problem list, write a description of what you believe is at the root of this pain issue so that I can describe exactly what you're describing to the patient, reinforce some of that same messaging. It actually helped us as a team both reinforce those messages, but also just forced us to really dig deep into the patient's history and really try to figure that out. Because in a lot of cases, we digged in, we had a problem on the problem list, but we didn't really have a theory as to where that pain was coming from.
Agreed.
Yeah.
Just to build on that, so for example, our second case, many individuals it just may say off the cuff, oh, this is fibromyalgia, and not look forward, for example. But I'll suggest, maybe there needs to be a little bit more attention there. Nice point.
Yeah, so I'm gonna bring us to our next question. I think this is maybe this is like the winner-take-all item here, but I think this person is essentially asking, what's the response to the patient who comes in and says, basically, I've had it all. I've been to the pain clinics. I've had, I worked with a mental health person on cognitive behavioral therapies. I've done this. I've done that. I've had, my fusion. I've had my injections. Where do you go with the person who says, I've done everything and nothing's helping me?
You want to tackle
I have the answer. No, I don't have the answer, but I have an answer, I guess, kind of, sort of. I mean, I think this is the most challenging situation, and unfortunately one that is not terribly unfamiliar. I think a lot of times when you ask people what has helped and they say nothing, and you say, what have you tried? And they say everything. You really have, which is, again, not an original experience. I think, one, you just have to dig deeper. You have to ask some questions about what exactly their experience has been. Really, what have they tried? What does try mean? Does it mean that you went somewhere but you never did anything outside of the hour that you spent with that person, be it something movement based or something behavioral based, or but really, so try to get a better idea of what that really means versus just kind of going, oh, okay, great, there's nothing. So that information is really helpful, those details. And then also at that point, I would just say start really, really small. I mean, again, as far as my, goal example, I mean, I think when you hear someone's story, that's why something like relaxation, which is so useful to me, is such a good thing to be able to go, how about we just try a little experiment? Would you be willing to do this for the next week or the next 2 weeks or the next, be really small, specific, and just say, would you be willing to just try this? And if it's a bust, we'll go back to the drawing board. I don't know if that's great, but that's kind of the practical answer, I would say.
Yes, and if I can build on that pragmatic approach. So when I hear that, and it's a very common problem to encounter, what I'm initially thinking of is expectation, right? Well, what, and I want to know the individual's expectation. So for example, I went to PT and it didn't work. I never want to do PT again. Well, what was your expectation with physical therapy? And then I get the response. Well, I went to 3 PT sessions. I still couldn't walk 10 miles a day, so therefore it's a failure. So sometimes there's just a true educational gap in what to expect from going to physical therapy, or what would you expect from an epidural steroid injection, for example. So I think understanding their expectations and then realigning treatments or providing educational information that might be needed to enhance a kind of re-engagement in some therapies that may not have been provided appropriately or in the wrong context. Great point.
Yeah. Yeah, and again, I think this is such a great question because it is what we see, and in addition to that, it tends to often be the case that maybe everything hasn't been tried to the extent that we prefer. But also, I find just messaging the patient, either way, we're going to stick with you through this, and we're going to help you see this through. So if this doesn't work, as Dr. Murphy mentioned, well, we're going to try something else, and we'll try something else, and I'm going to work with you and not kind of drop you just because this doesn't happen, and that often can kind of change the course as well. So we have more questions, and I think we have more to discuss, but we're out of time. So we'll go ahead and wrap up here. We have a little bit of contact information that we'll share with folks. And other than that, I'd like to thank our speakers, Drs. Murphy and Hooten. Thank you to CFHA and Dr. Serrano for co-sponsoring with us, the Primary Care Development Corporation. Again, a free recording of this will be available through our website and sent out to all of those who participated, as well as the link to the conversation tool that Dr. Murphy mentioned for helping to navigate some of these complex conversations with our patients. Any other parting remarks from our team here?
Thank
No,
you for doing this
thank you.
work. It was a privilege to participate.
Yes,
All right. Thank you, everyone.
thanks.
Thanks, everyone. Great job.